So we are going to get things started. Welcome to the 2022 Telehealth Summit, brought to you by the California Telehealth Resource Center. Pause for applause. We're glad that you guys can join us today. We're doing the Making Telehealth Work Insights from the California Safety Net. If you were planning on being at a different presentation, I encourage you to stay to this one, and hopefully this is the one you wanted all along. I'm Rob Kay. I'm the Technical Program Manager for Digital Patient Experience. In other words, I'm the MyChart guy for OCHIN. And in a previous life, I've run telehealth networks for large health systems. So this is near and dear to my heart. Some quick housekeeping components. Note that today's session is purely informational. The CTRC, California Telehealth Resource Center, has no relevant financial interest, arrangement, or affiliation with any of these organizations. And also note that we have another platform working in parallel. This is the WABA, the other platform that starts with the big W that we're using today. So feel free to use that to drop questions and monitor your engagement with the overall couple of days here. I will be keeping an eye on the chat both here in Zoom and on WABA. So feel free to drop them in either place. Also note that we are being recorded, so everyone on your best behavior. So with that, we have two guest speakers today, which I'm very excited about. We're going to start with Lori, who's just an expert in so many things. She's a senior policy researcher with RAND. Tactically, she's working deeply with California Healthcare Foundation to study telehealth, telemental health, teleactuation, telestroke, all the things with tele ahead of it that will be very interesting to this group. And she's working on evaluations for implementation at FQHCs. So this is deeply tactical for us. Following her will be Natasha Aurora, who's working with the Center for Community Health and Evaluation, which is part of Kaiser up in Washington. And there she works on health and social sectors with a focus on practical findings. So I'm excited to have this very tactical meeting with these guys. So we're going to have Lori go first. Feel free to drop questions as she goes, but I will be synthesizing those for the very end. And after her, Natasha will go. And on a personal note, once Natasha gets rolling, she is trained as a speech pathologist. And as a kid named Wab, who couldn't say his Ows, I deeply appreciate all of her work at work and look forward to the way that we can expand this to additional members. So first up, we have Lori. Take it away.
Great. Well, thanks so much, everyone. Good morning and welcome to our presentation on experiences implementing telehealth in safety net settings. So next slide, please. So you've seen this slide before, but just want to do, quick intro again. My name is Lori Usher-Pines. I'm going to kick off the presentation today, and then in a few minutes, I'm going to turn it over to Natasha. Both of our organizations actually help to evaluate the Connected Care Accelerator program. So we're going to be presenting on different components of that program today. I'm going to lead us off here with some description of telehealth utilization from the quantitative data that clinics submitted to us. Okay, next slide. Okay, just quick overview of our agenda. We're going to start with a presentation of learnings from the evaluation of the Connected Care Accelerator program, or CCA as we will refer to it. Then we're going to share some resources from the Center for Care Innovations, and these resources will be really helpful with respect to day-to-day implementation of telemedicine. And then finally, we'll wrap it up with some questions at the end. Next slide. Okay, so what is the Connected Care Accelerator program? In July 2020, the California Healthcare Foundation established a quality improvement initiative called CCA. And the goal of this initiative was to facilitate the transition to telehealth services that health centers were experiencing as a result of the COVID-19 pandemic. And what the initiative did is it provided funding, technical assistance, and peer learning opportunities to an initial cohort of 45 health centers in California. So we've been doing different activities with different subsets of that cohort of 45, but we started with 45 and then have branched out from there. So in some cases, I'll refer to data collection that we've conducted with a smaller set of them. That initial work lasted for about 18 months, but then we have ongoing efforts with our CCA health centers. We've continued data collection for an additional year with 33 of the original 45. And we're also pursuing an initiative called the Connected Care Accelerator Equity Collaborative. And Natasha can speak a little bit more about this. But the idea behind the Equity Collaborative is to rapidly design, test, scale, and share new strategies to improve equity and access to telehealth. So really getting at which populations are accessing telehealth more, which are accessing it less, and what can we do to bridge the digital divide. Next slide. Okay, so a little bit about our sample or initial cohort of 45 health centers. For the most part, these are large federally qualified health centers, although we have other safety net organizations as well represented. And in 2019, they had more than 500 different physical locations located across the state. These organizations served about 2 million patients in 2019. And we had about 20% of all federally qualified health centers in California represented in our sample. And in general, the FQHCs that were included were pretty similar to the non-participating FQHCs, so a fairly representative group. I'd say the one exception is that we didn't have quite as many small health centers represented in our sample, but large, diverse group of organizations participating. Next slide, please. Okay, so we analyzed data from a variety of different sources. And so this slide just really shows what some of our key data sources were. First of all, at any given time, between 33 and 45 health centers reported data to us on visits, on total utilization, and that was broken down by modalities. So we were able to see how many video visits, how many in-person visits, and how many audio-only visits were occurring each month from February 2019 through February 2022. So a year prior to the pandemic and 2 years into the pandemic. We also received information on patient demographics and who was being served by these different modalities, again, each month. We did a number of other data collection activities with around 23 health centers. First of all, we conducted interviews at 3 points in time, starting in October 2020. And here we talked to health center teams about their experiences implementing telemedicine, barriers, plans for the future. We had a variety of topics that we discussed, and to really put some of the quantitative data on visit trends in context to really understand what we were seeing in the quantitative data. We also conducted a survey of provider and care team experiences with telehealth, and that was a cross-sectional survey that was conducted in June 2021. We had about 600 respondents and a response rate of about 28%. And then finally, we reviewed project materials and artifacts created by the health centers throughout the course of the collaborative. So for example, if a health center developed a new workflow around telemedicine, we would be in a position to review that. Next slide. Okay, so I'm going to cover key finding number 1, and then Natasha's going to share key findings 2 through 4. And again, my slides are really focused on what's going on with visit trends during the pandemic. And a key finding in general is that telehealth replaced a large volume of in-person care in safety net settings during the COVID-19 pandemic. And this is true not only in safety net settings, but in the healthcare system more broadly. Interesting though, here we see that audio-only visits played a key role in telehealth delivery at the beginning of the pandemic, but they continue to play a key role. So one, really interesting thing that we're seeing is that audio-only visits continue to be a very important modality. And some of the qualitative data really sheds light on why that's the case. Next slide. Okay, so just getting into this main finding of the role of telemedicine. Next slide, please. Okay, so this slide shows trends in primary care visits per 1,000 patients by modality from February 2019 through February 2022. And as you can see from this top green line here, the visit rate remained relatively stable over the study period, with telehealth visits, in this case, mostly audio-only visits, substituting for in-person care during the pandemic. I'd like you to zero in on the final 6 months of the study period, so the period ending in February 2022, and that's the most recent data that we have. Here, we see that audio-only visits continued to decline from their peak in April 2020, and they were slowly replaced by in-person visits. You see the audio-only visits going down, you see the in-person visits coming back to take the dominant spot as the leading modality. On the other hand, video visits really remained relatively stable, and they continue to represent a smaller fraction of overall care. You see a little bump up at the beginning of the pandemic around March, April 2020, and then a little bit of growth, but in general, fairly steady utilization and video not making up, an important share of care. Next slide, please. Okay, so let's zero in on the last 3 months of the study period from December 2021 through February 2022. Here we can see exactly how visits broke down by modality. And during this time, the majority of visits, about 63%, were delivered in person. However, audio-only visits still represented a third of all visits, and video about 8% of all visits. And this is roughly among 1 million or so primary care visits that we were tracking during this time. Okay, so next slide. Go back a couple. Yeah, there we go. So this is a slide that's similar to the one I showed earlier, but in this case, we're focused on behavioral health visits rather than primary care visits. And here again, we're seeing that total visit volume in this green line remained pretty stable or even increased in this case. Although we're not seeing that it's a statistically significant increase, it does look, like if anything, health centers may be providing a few more behavioral health visits than they were prior to the pandemic. This suggests that with telemedicine, health centers in our sample were able to maintain access to care by leveraging audio only and video visits. What is different here, though, than for primary care is that telemedicine visits are still more common than in-person visits at these health centers. Although audio-only visits are still the dominant telehealth modality, there seems to be a larger role for video visits in behavioral health. So next slide, please. So let's zero in again on the most recent 3 months, December 2021 through February 2022. Here, 31% of visits were in person, 43% were audio only, and 26% were video. Visits here really are more equally distributed across modalities, in this case of behavioral health, as compared to primary care, where there's clearly a more dominant modality, that being in-person care. Interestingly, we're seeing cases where an FQHC may have high video use in behavioral health, but relatively low use in primary care. And this suggests that there may be clinic factors beyond just the digital divide that are contributing to lower video visit use in primary care. And this is something that we'd like to investigate further. Next slide. Okay, so I apologize in advance. This slide is pretty busy, but it presents data on the demographic characteristics of patients receiving different visit modalities. It shows the population of patients receiving video and audio only visits in 2022 and how that differs from the full clinic population served right before the pandemic in February 2020. And ideally, what we want to see is that the patient population receiving video visits is very similar to the overall clinic population. This would really align with the idea that they're not unique barriers to video visits among some populations, and that services were implemented in an equitable manner. And what we see here is that patients who prefer a language other than English, or the limited English proficiency population, they seem to be underrepresented in video visits in February 2022. And this is something that we were seeing throughout the pandemic. It's something important to watch from a health equity perspective, and something that Natasha is going to touch upon a little bit more. Okay, so at this point, I'd like to turn it over to Natasha to talk a little bit more about lessons learned in implementing telehealth and sharing some best practices.
Thanks, Lori. So the data that I'm going to speak to comes primarily from the set of interviews that we did with 23 of the participating health centers who participated in a learning collaborative facilitated by the Center for Care Innovations, and the learnings that they had as they worked to implement telehealth over the first year and a half or so of the pandemic. Slide, please. So Lori's talked quite a bit about the difference in use of telehealth by the two different modalities, audio only and video visits. And we know at this point that there isn't clear research about which modality may be better in certain cases, or whether there are particular cases in which video has an advantage in terms of quality of care. But we know that there are some situations in which visualizing a patient is important. And we also know that many providers have talked about the importance of that patient-provider connection that is more, facilitated in video. And we also know that there are concerns about the future reimbursement of audio-only visits. And so there's a large incentive for many health centers to move forward in implementing video visits. So one of the key focuses of our evaluation was in understanding what were the key implementation practices that supported the use of video visits within these FQHCs. So within these FQHCs, there were a few that actually used video at a significantly higher percentage than the average of the cohort. So there were a few health centers who did about 20 to 30% of their telehealth visits by video in both primary care and behavioral health. And we looked at those health centers to figure out what were the things they were doing that made video utilization possible at their health centers. Slide. In order for any of the health centers to implement video, they had to do quite a lot of legwork to get video off the ground. And so they needed to create procedures and workflows to determine when these video visits would occur and how to schedule them, to determine how to onboard patients to use the video visit platform, including many patients who were experiencing digital barriers. They needed to establish care team models that accounted for some of the additional demands of video telehealth, such as providing support to both patients and providers. And they also needed to determine how to connect interpreters to video visits, which in some cases proved challenging, given the constraints of some of these technologies in enabling three-way video calls. So Lori just spoke to some of the disparities in the data around limited English proficiency patients being served by video, and the interpreter challenge may be a piece of that. So for those health centers who were able to implement video at a higher rate, there were several key practices that they used to expand video utilization and make these video visits more accessible to their patients. The first was really dedicating significant operational resources to the activities that I just spoke to in the previous slide. And we'll hear some more about some of those later. The second, which I'll also speak to a little further as we move on, was selecting video visit platforms that were easy for patients to access. And the most important feature here is platforms that could be accessed by clicking a single link sent to a patient via a text message, rather than those that require downloading apps, accessing links via email, or accessing links via a patient portal. So this was really key for patients with limited experience using technology, or who didn't have access to certain forms of technology. The next piece that was really important was providing dedicated support to patients to orient them to video platforms. Like we've talked about, and as many of you are familiar with, many patients are new to the use of technology or don't have access to hardware. And the health center often played a role in facilitating that access to patients. Some health centers chose to schedule telehealth appointments as video by default. So they would have a process by which they determined whether an appointment could or should be done by telehealth. But if it was going to be done virtually, they chose video as a default, and sometimes used a script that said something like, your provider would like to see you by video. Do you have a device that you can use to do that? And if the patient was able to do video, that was the default. If they didn't have access to the means to do video, then the appointment was converted to audio only. And some health centers that had a pretty high video utilization rate also had set targets or quotas for the use of specific appointment modalities within telehealth in order to promote that video visit usage among their providers. So these were the pieces that really went into promoting video visits specifically, but there's a lot that goes into the use of telehealth overall, including the audio only appointments, which I'll talk about shortly. Slide, please. So in order to implement telehealth at all, health centers really needed to establish the necessary infrastructure around staffing models, technology, and operational changes to facilitate a pretty major transition into how they were delivering care. And so we'll talk about some of the promising practices that the evaluation identified related to these operational changes, staffing models, and technology. Slide. So the promising practices that we learned about related to operational changes will be familiar to any of you who have engaged in clinical process improvement work before. So I won't spend a lot of time on them. But health centers really needed to create and standardize workflows across all parts of a telehealth clinical encounters that went all the way from scheduling to visit follow-up. And they also really needed to coordinate across IT, operations, and clinical teams. And one of the things we saw during this period was an attempt to create a lot of processes and workflows within the health center operations teams, and then transfer those and train the clinical teams to be able to take on some of those pieces. And in order to do all of this, it helped to have some clearly defined goals and to use rapid cycle improvement processes, both of which were emphasized during the Connected Care Accelerator Learning Collaborative. Slide. So I'd like to share some examples of workflows that health centers came up with. The first one here is a partial view. You'll see some more on the next slide just because of space constraints, is from West County Health Centers. And they implemented a pretty unique model in terms of how they delivered telehealth within their clinic workflow by using Zoom breakout rooms to essentially replicate the layout of a brick and mortar clinic. And so they had a breakout room that was a virtual waiting room, and a concierge would admit the patient into that waiting room. They would verify the patient, make sure that their name appeared appropriately in Zoom, and then they would move those patients into an exam room. Slide. And providers and care team members could move between these exam rooms as well as a workroom created for providers and care team members as sort of their home base, just as you would do within a brick and mortar clinic. So walking into a patient room, walking out, communicating with other care team members. So this was a pretty unique implementation of telehealth and video telehealth, and involved, a lot of refining of workflows and care team processes in order to get there. So that's one example of a workflow that one of the health centers participating in this initiative developed. I'll share another one right here, slide. This one is from Petaluma Health Center, and it's their workflow for their tech volunteers. So as I've mentioned before, one of the big challenges of implementing telehealth in the safety net, and one area with a lot of potential, is in supporting patients to access technology that they may not be familiar with. So Petaluma Health Center used some tech volunteers to call patients and help them make sure that they were equipped in advance of their virtual appointments. And this was the workflow to make sure that they had the right technology, that their portal access was correct, that they had the app downloaded, et cetera, and to get them ready to do that appointment. Slide. So health centers had to do a lot of work, as we've seen in the last couple of slides, around their staffing models and their care teams in order to meet some of the demands of telehealth. There wasn't a single model around staffing or care teams that proved to be, more useful than others. It really was about individual health centers finding the right model that worked for their team. So most health center teams told us that providing telehealth appointments increased the responsibilities of their medical assistants in particular, who were often responsible for tasks such as making calls ahead of visits. You saw that in the previous workflow as done by volunteers, calling patients who had trouble logging on to visits. So a lot of health centers looked to strategies to relieve some of those burdens in order to enable MAs to focus on their clinical responsibilities. So a few health centers did this by creating a telehealth coordinator role, which was sometimes filled by current MAs, but didn't require the specific clinical skills of medical assistants. And these coordinators were responsible for providing support to both patients and providers to connect to telehealth visits. And in other cases, health centers assigned some of their more tech-savvy MAs to be working specifically with providers who were conducting telehealth visits. And others used volunteers, like you saw in the previous workflow, to complete some of the tasks that would have otherwise fallen on front office staff or back office staff in order to relieve some of those responsibilities. Slide, please. So in terms of promising practices, again, there wasn't a specific model that worked best for distributing responsibilities across staff and care teams. But there were a few common promising practices around staffing telehealth that we learned about that worked through these various models. The first was really to make sure that care teams had a way to collaborate digitally and replicate some of the informal communication that occurs while providing in-person care. So in some cases, this was via chat platforms such as Teams or through the use of breakout rooms in platforms like Zoom, like we saw in the West County workflow. And this was especially important if providers were working from home or from other clinic locations. The next was to make sure that the new responsibilities associated with telehealth were clearly delegated to either a new or existing role, and that the staffing was adequate to accommodate these. And I know that over the last year in particular, we've been hearing about the challenges associated with that, as health center staffing has been a significant challenge, especially among support staff. And finally, many teams named that it was helpful to delegate overall responsibility to managing telehealth to a manager or coordinator role. And as we've seen, there's a lot of details involved in implementing and expanding telehealth. And it was really a significant driver of success to have someone accountable for managing all of these pieces. We really did hear about the importance of MAs frequently. So I want to reemphasize that point, and that the role of the MA changed a lot. MAs often took on new responsibilities, and getting them to actually be able to do that as well as resume their clinical responsibilities within a visit. So completing pre-visit and post-visit tasks was really important, and is an area in which many health centers are still working on expanding that. Slide, please. So we also learned about some promising practices related to technology. Some health centers adopted new telehealth platforms during the pandemic as they launched their telehealth programs, while others had existing vendor contracts in place. And health centers also adopted or expanded their use of related technologies, such as patient portals, remote patient monitoring tools, and patient messaging platforms. One of the big decisions that health centers had to make was often whether or not to pursue EHR integrated solutions for video visits versus a standalone platform. And given the many different EHRs and platforms and vendors out there, there's not necessarily a single right answer for this. But what we did find was that in the safety net context, the single most important feature for patients was the ability to log on directly to a visit through a link, like I mentioned before. And that wasn't always available through EHR integrated solutions, although there seemed to be constant changes occurring in what's available from each of these vendors. Some other important features for patients were virtual waiting rooms where they could receive messages from clinic staff. We heard that one of the challenges of the virtual waiting room was sometimes that patients were left there and didn't realize that the provider would be coming in to see them, or the MA would be coming in to see them, and so they would simply leave. Three-way calling for interpreter services, which is a really important aspect of equitable telehealth delivery, The ability to share photos. In some cases, video images would be grainy, but if a photo could be uploaded, that was more useful to a provider who is trying to visualize something like a rash or a wound. And electronic registration forms, which enabled new patients to be seen via video and audio only visits. It was also really important for patients to be able to test out platforms prior to scheduled visits, especially for those less familiar with technology. That was often part of the patient support role in providing support to patients, was doing essentially a rehearsal of the visit to make sure that patients understood the technology. And that way, less of the technology troubleshooting and time delays would fall on the provider or the care team. And then on the back end, integration with other technology was a really helpful feature, as well as features that allowed providers and care teams to communicate among themselves, like we talked about before. Slide, please. So as I mentioned earlier, a lot of patients in the safety net experience digital barriers that make it challenging for them to connect to telehealth. But we heard that a lot of patients were actually really eager and interested in learning about technology and received support from their families and communities to get connected. So this is also an area to see as a big area of potential for patients to access care. And health centers tried out many different strategies to reach their patients and support them to get onto telehealth visits. So we'll look at a few of those now. There's a few examples here of what health centers in the Learning Collaborative tried out, and there were other strategies that you'll see in the resources that we'll share later today. As one example, one health center used their health education team to help patients, particularly those that were less familiar with technology, learn how to get onto video visits. So that was a new use of their health education team. And in other cases, health centers had student volunteers support virtual patient rooming and connecting with patients one-on-one who needed help accessing the video visit or telehealth platform for the first time and wanted to get some practice ahead of time. And these practice visits helped the actual visit go more smoothly to save some time for providers and care teams. Clinics also created a lot of resources, including websites and videos, often in multiple languages, or conducted text messaging campaigns to get information out to patients on how to access telehealth. And as we discussed earlier, in some cases, they also created new positions in their staff to assume the responsibility of supporting patients with telehealth. Slide, please. So there were a few promising practices that we identified related to supporting patients with digital barriers. The first was systematically screening patients for technology access and their needs for support at the time of visit scheduling by asking questions both about what technology they had access to and what they're familiar doing with it. So this helped to identify patients who were able to do telehealth visits and also ones that would need extra support to get online. The next was to develop clear processes and workflows relating to providing that support with patients, like we've discussed, which could include conducting practice visits or pulling in a team member to provide one-on-one support to a patient. The third was to use a variety of access points to disseminate information to patients on telehealth. That included the web pages and texting that I mentioned, and in some cases, sharing information with patients when they were physically in the clinic and waiting rooms. And finally, health centers found that providers really played a key role in this process of supporting patients, as patients were often most receptive to provider encouragement. Often that's the most familiar person to patients within their care team. And if the providers were encouraging these visits, patients often seemed more willing to try some new technology. Slide, please. So here's an example from the San Francisco Department of Public Health around their screening for digital barriers. So they would make a call to the patient and ask whether the patient wanted to try a video visit instead of a telephone visit. And they had some particular questions they needed to ask around having a device with a camera, having Wi-Fi or an unlimited data plan. They wanted to make sure they weren't burdening patients by asking them to use limited data to conduct a video visit that might have not been very accessible to them financially. Slide, please. Oh, sorry, I thought there was a second piece there. So the health centers came up with a variety of screening tools, and a lot of those are available within the Center for Care Innovation resource library that I'll share shortly. So with all of these promising practices that were identified, health centers made a lot of progress within their implementation of telehealth, and also found that they have a long way to go. So I'll wrap up with a few thoughts on next steps that health centers shared with us, and then also with some current learnings about where health centers are that are participating in the Equity Collaborative, the new iteration of the Connected Care Accelerator, and then share some resources, and then we'll shift to Q&A. So many health centers commented that their next step is to transition from a reactive model of care that emerged during the pandemic to something more sustainable for the long run. And they talked about the need for an evidence-based model that's responsive to their patients' needs, and a more seamless operational model that combines telehealth and in-person offerings. They wanted to continue to expand access, offering access to their patients more equitably by continuing to address the digital barriers that patients are experiencing through some of the strategies that we've already discussed, as well as additional strategies. And finally, health centers really emphasize the importance of reimbursement models that will allow them to keep providing telehealth services, including some continued reimbursement for audio-only visits. Slide, please. So in terms of where some of these health centers are now, the Connected Care Accelerator is in its second iteration with a program referred to as the Connected Care Accelerator Equity Collaborative, which, as Lori described at the beginning of our presentation, aims to provide a testing ground for organizations to design, test, and share solutions, particularly within 3 areas, which are improving the use of video telehealth using some of the learnings that we just discussed, supporting patients with digital barriers, also using some of the learnings we just discussed, and expanding access to telehealth for patients with a preferred language other than English. That third area has really emerged as important from the data that Lori shared earlier, and the disparity that we see in the access to video telehealth among patients with limited English proficiency. And on a practical level, one of the challenges with expanding access to patients with limited English proficiency is the connection of interpreters to the visit, which in many cases was done informally during the last couple of years via, for example, a provider being connected to a video visit with a patient and then having a separate phone line on which an interpreter was connected. So not a great connection. So there's really a need to explore solutions in that area. So there's 22 health centers participating in this iteration of the Connected Care Accelerator. And part of the evaluation work that we're doing includes an assessment, a capacity assessment of equitable telehealth practices adapted from the work of Dr. Jim Myers, who created a telehealth maturity model. Slide, please. So as we think about equity and delivery of telehealth, we're really thinking of it across a variety of areas and how equity plays into each of those. So for example, the first one, software, technology, and technology support, we have some learnings about what types of technology are easier or more practical for patients to access, as well as some learnings around language access to technology. So we're really looking at how does that impact equity and telehealth delivery. There's also, other areas in this assessment around workflows and team-based care, patient engagement and support, which is a lot of what I talked about earlier, strategy, leadership, and governance, and then data and quality improvement. So we have some very preliminary data here. I think you all are the first people we're sharing some of this very preliminary data with around where health centers are now in some of the areas that I've talked about throughout this presentation. And we're finding that there's been significant progress made in some of these areas, such as refining workflows and team-based care processes, and that there are also some areas in which there continue to remain challenges and the need for investment of resources and testing and designing new solutions. Slide. So some of what we've learned very recently around the development of telehealth infrastructure and operations among these clinics is that most organizations have developed protocols around when to use telehealth. And most of them indicate that they've made significant effort around integrating telehealth into their standard care operations and standardized processes across sites. They've made progress on integrating team-based care into telehealth visits, which happened a little more ad hoc at the beginning of the pandemic in terms of defining the MA role or the role of other care team members. They've developed really clear processes around check-in, pre-visit screenings, and post-visit tasks for most organizations. But they also continue to experience some challenges. One of the key ones is around integrating multiple team members into visits and being able to share patient education materials. So some of these pieces that really support quality of care within a brick and mortar clinic have still been challenging to implement via telehealth. And overall, we're also seeing that workflows are more developed for audio-only visits versus video visits, which is not surprising given the utilization numbers that we've seen. Slide. In terms of providing support to patients, most organizations indicate that they haven't yet implemented a screening process for looking at patient digital barriers, or that screening is occurring, but is occurring with relatively few patients. In terms of technology, at this point, most organizations indicate that they're using a telehealth platform that doesn't require downloads or doesn't require the use of a patient portal. So it's relatively easy to access for patients. So they've been able to make progress towards making telehealth more accessible to patients with digital barriers. A couple of organizations have also explored providing support to patients who don't have devices or don't have connectivity. And that's something that we were hearing about a variety of innovative solutions in that area, such as distributing devices or having Wi-Fi accessible to patients at the height of the pandemic within like a parking lot or an area that was more accessible to patients without having them walk into the clinic. Obviously, as the pandemic evolves, the solutions related to that also are evolving. Slide. So given all of that, we want to make sure that you have access to the resources that were created by health centers and put together by the Center for Care Innovations throughout this initiative. You can find those at the link here, which is careinnovations.org/journey-map. And I'll paste that in the chat as well. This is a screenshot of the journey map that Center for Care Innovations created, which has a variety of virtual visit resources. Slide. And these resources walk you through each of the phases of a virtual visit, all the way from appointment making to confirmation, pre-visit support, the visit itself, and the post-visit follow-up in several different areas. And there's many types of resources included here. So all of the screenshots of health center artifacts that I shared in this presentation are also in this journey map slide. So some examples of the types of things you might find, which are directly translatable for other clinic environments, are flyers around how to access video visits that were created in a variety of languages. There's one here from Northeast Medical Services created in Chinese. Patient education materials. There's one example here around self-monitoring of blood pressure. Surveys of patient satisfaction with their telehealth experience. The one here is from Monterey County, and they're actually one of the few county health systems that had a relatively high video utilization. And so there's a lot of interesting resources here, and hope you get a chance to explore them. So I will paste that link in the chat. And with that, we would love to transition to getting some questions from all of you. So thank you.
Wow. I will provide applause from the audience because I know everyone is muted. That was so much and so tactical and interesting. Thank you both. Lori, it was amazing to see. I was surprised to see that initial data that as COVID struck, it went all audio and video barely budged. And it makes sense that behavioral health took up some of the video, but I was surprised, and as a longtime telehealth soul, pretty disappointed that that video didn't get an uptick. And then Natasha, so many resources. I think there's the elephant in the room, which is, what is reimbursement policy going to be once the health emergency is over? But assuming that telehealth in some way, shape, or form is here to stay, I love how deep you went on the barriers that are faced. I know that I feel like I'm not alone anymore, that we're not the only ones facing these problems, and that staffing and training can be so hard, and good to hear that the MAs are critical there. A couple of quick tactical questions from the crew. One is, how do you register and sign up, Natasha, to join the Connected Care Accelerator collaborator?
I believe that at this point, the applications are closed and that cohort is established, but I would suggest going to the Center for Care Innovations page and signing up for all of their resources, as they continue to have a variety of programs that might be of interest, and all of the resources there are freely available. And they also have other freely available events, webinars, things like that. So I would suggest exploring their page to start.
Got it. So explore what's there today and keep an eye out for a potential future cohort, but nothing open right now. And then a pretty tactical question. I know you said, and I loved hearing that text messaging links was really the number one patient flow enabler. And going with that is, how important is launching a program that is fully integrated with the EHR, whether that's Epic or Cerner or anything, versus other experiences? How important is that integration, both for the clinical side and the patient side?
I mean, I don't think we have a 100% clear answer here. I think in many cases during this phase of implementation, I think organizations found that they were facing a trade-off, and that may change as technology continues to evolve and the offerings of vendors continue to evolve. But a lot of organizations found that if they were using an integrated solution, it required access via, for example, a patient portal, and that became a challenge for patients, an accessibility challenge. So it seems to me that the ideal solution is one that incorporates both, that on the back end, is a smooth process for providers, staff, care team members, and also provides that facility of access to patients. And that wasn't always a possibility. And so many health centers were using standalone platforms because they were more accessible to patients. So I think that this, continues to require exploration within each individual health center. And I know that one of the resources available on the Center for Care Innovations journey map, I believe, is a set of criteria for selection of telehealth platforms and vendors. And that might be something helpful to look at. Lori, would you add anything?
The only thing I might add is that, we surveyed our health centers relatively early on in the pandemic, maybe 6 months in, and many of them were using multiple platforms. If there was failure with one, they could turn to another. And that may be an important, digital equity strategy, that you have redundancy and you provide a platform that's preferred by patients and give them the choice.
Got it. And I know this presentation is platform agnostic. I can briefly speak to Ochen's Epic. We generally are integrated with Zoom, but do have a secondary tool of Doximity, where if the MyChart integration doesn't work, the patient can't find it, then your providers can call it. So that rings true to me. Curious about, you talk about essentially that pitch to patients and how what's in it for them. You mentioned how having the providers kind of close the deal was important, but to a patient, phone call is easy. To a provider, a phone call is easy. Why are we even going down this road? This is just getting hard. So what's part of that pitch that your schedulers are doing to help patients sign up for this?
Is that question about video telehealth particularly?
Yeah.
Yeah, I mean, I think that's an evolving question of what's in that for patients. I think we've heard frequently about the importance of the connection between patient and provider, and the potential for video to have a role there. I think that, we're hearing a variety of things from providers. We didn't present on the provider and staff survey data that we did within this presentation, but it seems like there's a role for video in some cases and a role for audio only visits in other cases, and that there isn't a single answer. But I think for patients, it makes sense to encourage them to use video in cases where video is going to facilitate better care, and for them to be able to understand when that's true, whether it's the need to be able to visualize something specific, like an injury or a skin lesion, or whether it's more about patient and provider being able to connect, being able to read body language, being able to understand some of the factors that might be contributing to their health challenges.
Got it. Thank you. And I think another big takeaway I got from your presentation, Natasha, was telehealth as a whole freaked out at the beginning of COVID, and we scrambled to put things together. And we are now generally at the point where we can catch a breath, sort of, and I know I'm not frontlining, so I don't want to project too hard, but there's a chance to catch your breath and kind of re-implement. And it sounds like one of the big themes is to do that thoughtfully, and that it takes, you have to actually think through it. You can't just keep going, throwing things together, that there will be staffing constraints, and Lord knows FQHCs struggle with that already, but you need to think about how you're staffing for this. And so taking that step back and having it as an organizational priority. What have you seen work well in getting that kind of executive buy-in, that leadership buy-in to get telehealth as a focus to do that step back and holistic review? And that's to either of you. What have you seen work there?
Lori, do you have anything you'd want to say around reimbursement related to that?
Sure. So a couple things. I mean, I think we've heard many times that when there's a clinic champion for telemedicine, that's a big driver of successful implementation. And that's also applying to having a high proportion of video visits, right? If it's really an organizational priority to make video visits happen and replace audio only visits with video visits, that will go a really long way. Right now, Congress is pursuing what we like to call, a kick the can strategy on telemedicine at the federal level, where right now it looks like a lot of the flexibilities will sunset 5 months after the end of the PHE, but then this new Cheney bill that just passed the House says that many of the flexibilities, including reimbursement for audio only visits, will continue until 2024. So maybe, this idea that there's more time to gather data, to implement programs that will allow health centers and other entities in the healthcare system to really do this thoughtfully. We joke that, at the beginning of the pandemic, it was telehealth by desperation. And so there wasn't this, opportunity to really optimize telehealth services. And now, at least there may be on the federal level, a 2-year period where we can implement slowly and thoughtfully.
Got it. Anything to add to that, Natasha?
I would just add also the importance of provider leadership in telehealth implementation. I think a lot of the health centers who did great work around video or who had higher rates of video utilization really did that by starting with a couple of providers who were very bought into that work and then, spread it among the rest of their staff. So leadership at all levels, including provider leadership.
That makes sense. And I think we're sort of drawing to a close here. I want to note a great comment from Elaine in the chat on HUVA, that a lot of NPs and even docs are going with just a phone rather than video because of the simplicity and because it doesn't require auxiliary staff. And while that hurts me in my telehealth core, and especially as a technologist, I think we can do better at making this simple. I very much understand, especially when serving these populations. So taking a final step back, we've covered a lot of ground on watching how the data changes over COVID. There's an opportunity to basically beg, borrow, and steal workflows as shared by Natasha, with those links she at the Care Innovations. Lori covered, the way that behavioral health might be ripe for work, and really getting your providers and MAs on board while getting paid seems to be critical. Speaking of getting paid, and a shameless plug, Sylvia mentions that later today we have a law and policy session all about reimbursement and the future of it, but I appreciated that sneak peek on the kick the can policy that we're all currently enjoying. So with a silent applauding, I want to thank Lori and Natasha for the great presentation. Again, this will all be recorded and available for review, but go click around those websites and we'll see you at other events. Thank you.